start. So yeah, in the previous class we had discussed about small intestine and the pathologies related to that. Today we are starting with pathologies related to large intestine. Okay, large intestine starts from, as we all know, cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and then ending with rectum and anal canal. Okay, so rectum and anal canal we'll discuss it separately, and vermiform appendix related to appendicitis we'll discuss it separately, and inflammatory bowel diseases we'll discuss it separately. Okay, so in today's class we'll just be dealing with four basic pathologies related to large intestine, that is Hirschsprung's disease or megacolon, and then polyps, mainly familial adenomatous polyposis and hereditary non-polyposis colorectal cancer, and then CA colon. Okay, after this we'll have a brief discussion about ileostomy and colostomy. So these are the two surgical procedures which are usually performed. So what are they? What are the types of ileostomy and colostomy? How is they useful? Everything, all this we'll discuss today. Okay. So yeah, starting with the first pathology of large intestine, that is Hirschsprung's disease. So incidence, it is almost seen 1 in 5,000 live births, and it is basically a congenital disease or an acquired disease, you can say, in which there will be absence of ganglion cells in both Auerbach and Meissner's plexus. So we all know these are the two plexus which are present in the gastrointestinal system or GIT, where these will be regulating secretions as well as peristalsis. So Auerbach's plexus is called as myenteric plexus. This will regulate peristalsis, whereas Meissner's plexus is the submucosal plexus, and this will regulate secretions in the GIT. Okay, so basically these two are necessary for peristalsis. If there is an absence of these ganglion cells in both these, then there will be no peristalsis. Basically this will act like a obstruction. Okay, so with this ideology we'll go further. So most common site where these ganglion cells are absent will be most commonly rectum, and it is sigmoid. What we have to understand is, complete throughout the large intestine these ganglion cells will not be absent. There will be a partial absence. In a certain region there will be absence, and in certain region they will be present. Okay, ganglion cells will be absent only in certain regions of large intestine. Why is this absence in certain region? Because of failure of migration of neural crest cells to colonic mucosa. Wherever this migration of neural crest cells is failed, only in that region there will be absence of ganglion cells. That will lead to Hirschsprung's disease. Okay, so what will be the severity and symptoms and age of presentation in this case? It will depend upon the length of segment involved. So what length of colon has this absence of migration of neural crest cells, that will decide the severity and symptoms. Okay, so these can be clinically seen in three age groups. So it can be seen just after birth, or it can be present in patients with first few weeks of life, that is neonates, and in older children and adults. Okay, so just after birth, if it is presented, then there will be, how can we identify what will be the clinical features if it is present just after birth? There will be delay of passage of meconium. Meconium is the first stools passed by a neonate just born. So if there is delay in passage of this meconium, then that says that there is absence of peristalsis, and that can be dependent on Hirschsprung's disease. So if the segment involved is longer, then the obstruction will be severe. Otherwise, most commonly the symptom will be abdominal distension. So usually we will assess passage of urine and passage of stools in newborns, right? If there is delay in passage of meconium or stools, then we'll have to look for abdominal distension. If both of these are there, then there is a high chance that there is Hirschsprung's disease. Okay, if the disease presents after first few weeks of life, there will be usually chronic constipation, and then abdominal distension again will be there, and there will be failure to thrive. Okay, if it is presenting in older children and adults, basically chronic constipation. Okay, so what is the investigation we'll do in case of Hirschsprung's disease? Investigation of choice for diagnosis, definitely this is Hirschsprung's ಅಂತ ಹೇಳಬೇಕು ಅಂದರೆ we will do rectal biopsy, that too full thickness biopsy. So biopsy ಮಾಡಿ ಏನು ಮಾಡ್ತೀವಿ, we'll look under histopathological examination, and under that what will be the findings? There will be aganglionosis, that is absence of the ganglion cells in both myenteric as well as Meissner's plexus. After that, the nerve trunks whatever is left, that will be hypertrophied, and there will be positive acetylcholinesterase action in that staining. Okay, so these three are the features in biopsy. So okay, after this we have come to know that this is Hirschsprung's disease, or this is also called as congenital megacolon. Okay, ಸೊ ಇದು ನೇಮ್ ಏನು ಹೇಳ್ತಾ ಇದೆ, ಕಂಜನೈಟಲ್ ಅಂದರೆ ಓಕೆ ಚಿಲ್ಡ್ರನಲ್ಲಿ ಕಾಣಿಸುತ್ತೆ, ಮೆಗಾ ಕೊಲಾನ್ ಬಿಗ್ ಕೊಲಾನ್, ಕೊಲಾನ್ ಇಟ್ ಸೆಲ್ಫ್ ಇಸ್ ಬಿಗ್, ಅದರ್ ದ್ಯಾನ್ ದಟ್ there is dilatation of the colon because there is absence of peristalsis. Whatever the food is there which is entering the colon, that is getting accumulated there itself, leading to increased distension, and that leading to a bigger colon, that is called as megacolon. Okay, so once we diagnose this, how will we manage this case? If there is only a short segment of disease, then we will go for extended myectomy. Whatever the short segment is involved, we will cut off that part of colon and then just anastomosis, basically resect and anastomosis type. If there is long segment, then we will have to go for temporary colostomy followed by definitive operations like Swenson, Duhamel or Serve procedure. In this, temporary colostomy means just creating an opening from the colon, like ಯಾವ ಪಾರ್ಟ್ ಇವಾಗ ಈ ಥರ ಇದೆ ಅಂತ ಅಂದ್ಕೊಳ್ಳೋಣ. ಸೊ ಇಲ್ಲಿ ಈ ರೀಸನಿಂದ ದೇರ್ ಈಸ್ ಆಬ್ಸೆನ್ಸ್ ಆಫ್ ganglion cells. Okay, because of that reason there is megacolon here. So what we will do, we will take this part of the colon and we will create an opening in the abdomen, and this is called as colostomy. This is temporarily, we will create a temporary colostomy so that food is not passing from here to here, instead it is passing outwards through this hole we have created in the abdomen. Okay, after that what we can do, whatever the part is there, we can identify that part and resect this and anastomose. So basically resection and anastomosis procedures for Hirschsprung's disease, definitive procedures, involves name based on the scientist, that is Swenson or Duhamel or Serve procedures. Godaitalla, we will create, if the long segment is involved, then we will do temporary colostomy, and then we will just create this thing, we will just resect and then we will anastomose this. Okay, this was about Hirschsprung's disease. After this, we will start with major topic, that is colorectal polyp. So it can be in the colon or it can be in the rectum, and it is a polyp. Okay, so that itself is the definition of this. So there are two types of polyps mainly. We can divide these colorectal polyps as two types, which are neoplastic or cancerous, or which are non-neoplastic or non-cancerous. Okay, so neoplastic ones are again based on the appearance. They can be divided as tubular or villous or tubovillous. Okay, so most common benign one is tubular, whereas most malignant is villous type of neoplastic polyp or adenomatous polyp, whereas most common overall is non-neoplastic, and that is hyperplastic polyp. There can be various hamartomatous polyps also. They can be juvenile polyps or Peutz-Jeghers polyp, and there can be inflammatory polyps. So we'll discuss these non-neoplastic polyps one by one, and then we'll come to know what exactly we are speaking about. Okay, so these are some takeaway points which we need to know about colorectal polyps. Overall, the most common type of colorectal polyp is non-neoplastic, that is hyperplastic polyp. Overall, most common neoplastic polyp is tubular, and in that this is benign. Overall, most common malignant colorectal polyp is villous type of polyp. Okay, similarly we need to know about some gastric polyps also. Most common type of gastric polyp is hyperplastic, again similar to colorectal polyp. Most common neoplastic gastric polyp is tubular, neoplastic gastric polyp. Malignant is again villous polyp. Same in colorectal polyp as well as in gastric polyps, these points are same. Okay, that's why in comparison they have given here. Okay, after this we'll start with non-neoplastic polyps. In non-neoplastic polyp, we discussed hyperplastic is the most common one. After that, we discussed there can be juvenile polyp and Peutz-Jeghers polyp. So what is juvenile polyp exactly? Juvenile polyp Nothing but juvenile andre 5 to 14 years of age or children anta basically. So juvenile is seen in children under 5 years of age and most common site being rectum. Okay. So clinical presentation ಏನಿರುತ್ತೆ, polyp ಅಂದ್ರೇನು, mucus, some mucosa is protruded like this. Okay, so this is polyp. Whenever a food passes or whenever there is peristaltic, there can be bleeding. Hence the clinical presentation most common way will be bleeding per rectum associated with, since this mucosa is hyperplastic now, all this mucosa will secrete secretions, that will be mucus. So plus bleeding per rectum, so bleeding plus mucus along, and the most common site is rectum. So this will be the clinical feature. Bleeding and mucus discharge from the rectum will be the clinical feature in case of juvenile polyp. So what is the management? So we'll do colonoscopy, we'll see where exactly the polyp is. If there is in the rectum, then we'll remove that polyp, and that procedure is called as polypectomy, removal of polyp. That's it. There is a syndrome called as juvenile polyposis syndrome. In case of juvenile polyp, it was individual polyp, one polyp. Okay. In case of juvenile polyposis syndrome, there will be multiple juvenile polyps, and these both juvenile polyp and juvenile polyposis syndrome, they are non-neoplastic. Okay, hence they have lower risk of malignancy. But on comparison, juvenile polyposis syndrome andre multiple polyps idre always increased risk than juvenile polyp ashte. So again, one more non-neoplastic polyp, that is Peutz-Jeghers syndrome, PJ syndrome. This is actually a genetic disorder. Okay, so ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, there will be multipus hamartomatous polyps. Basically blood vessel tumor ತರ ಕಾಣಿಸ್ತಿರುತ್ತೆ, ರೆಡ್, ಅದಕ್ಕೆ hamartomatous polyps ಅಂತ ಕರೀತಾರೆ. Okay, so multiple ಇರುತ್ತೆ, ಒಂದಿರಲ್ಲ, multiple hamartomatous polyps. This can be present anywhere in the gastrointestinal tract throughout the GIT, from esophagus to anal canal, ಎಲ್ಲಿಂದ ಬೇಕಾದರೂ ಇರ್ಬೋದು. Most common site being small intestine, and it can be present in colon also, hence we are discussing it under large intestine. So most common site is actually small intestine, but we are discussing it under colon. Okay, so here ಏನಾಗಿರುತ್ತೆ, just like I said, it is a genetic disorder. There is a genetic mutation, and that mutated gene is LKB gene or STK11, which is present on the chromosome 11. ಈ gene mutation ಆದರೆ ಏನಾಗುತ್ತೆ, related to cell proliferation, some disease might happen, and that will lead to multiple hamartomatous polyps throughout the GIT. Okay, so ಇಲ್ಲೇನಾಗಿರುತ್ತೆ, it is characterized by hypermelanotic macules. Basically over the lips and buccal mucosa ಏನಾಗಿರುತ್ತೆ, there will be blackish pigmentation, excessive melanotic macules. So along with multiple hamartomatous GI polyps. So it is involving two systems here. One is skin, that is blackish pigmentation around lips and oral or buccal mucosa. Okay, this is one manifestation. Along with that, there will be multiple hamartomatous polyps throughout the GIT. So if these two features are given, like a patient presented to your clinic with multiple hamartomatous polyps and blackish discoloration around the lips and oral mucosa, what is the mutation you will expect here? Ee tara questions keltare. So in that case, that is LKB1 and STK11, and that syndrome is a Peutz-Jeghers syndrome. Okay, what will be the clinical features and what exactly is the pathology is? It shows arborization and pseudo invasion of GI tract or mucosa. Okay, so clinical features ಏನಿರುತ್ತೆ, recurrent intussusception ಆಗ್ತಿರುತ್ತೆ ಇವ್ರಿಗೆ, that leads to recurrent abdominal pain, and polyp acts as a lead point. Okay, one thing we need to know about this is Peutz-Jeghers syndrome doesn't increase the risk of colorectal cancer. It is not a risk factor for colorectal cancer. Even though there are multiple polyps, colorectal cancer cause ಮಾಡಲ್ಲ ಇದು, but it can lead to many other cancers like small intestine malignancy ಇರ್ಬೋದು, pancreatic malignancy ಇರ್ಬೋದು, breast cancer, thyroid cancer, endometrial cancer, sertolic cell tumor. ಇದೆಲ್ಲದನ್ನು it is a risk factor, but it is not a risk factor for colorectal cancer. Okay, so now other non-neoplastic polyp is inflammatory polyp. It is also called as pseudopolyp. Okay, this is usually seen in case of inflammatory bowel diseases. It is usually non-malignant, but these inflammatory bowel diseases in which this is seen, those are ulcerative colitis and Crohn's disease. These are pre-malignant conditions. These are pre-malignant, but as of per se, inflammatory polyps will not cause colorectal cancer. So this brought us to the end of non-neoplastic polyps, which we have discussed. We have discussed hematomatous, that is juvenile and pure sugar, and inflammatory polyps. Hyperplastic is not much needed. ಅಲ್ಲಿ ಇನ್ನೇನಾಗಿರಲ್ಲ, ಹೈಪರ್ಪ್ಲೇಸಿಯಾ ಆಗ್ತಿರುತ್ತೆ, ಸೆಲ್ಸ್ ತುಂಬ ಮಲ್ಟಿಪ್ಲೈ ಆಗಿ ಗ್ರೋ ಆಗ್ತಿರುತ್ತೆ. Because of that reason it will form polyps. Okay, so next, coming to two main important, that is adenomatous, or you can say neoplastic polyps. Okay, so this is a pre-malignant polyp, and the conditions which increase the risk of adenomatous polyp are ureterosigmoidostomy, okay, streptococcus bovis bacteremia, and acromegaly. ಇದ್ರ ಅಸೋಸಿಯೇಷನ್ ತಿಳ್ಕೊತಾ ಹೋದರೆ ತುಂಬ ಆಗೋಗುತ್ತೆ. ಜಸ್ಟ್ ರಿಮೆಂಬರ್, ಯು ಎಸ್ ಎ ಈಸ್ ಅ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ ಫಾರ್ ಅಡಿನೋಮ್ಯಾಟಸ್ ಪಾಲಿಪ್. ಯು ಎಸ್ ಎ ಏನು, ಯುರೆಟರೋ ಸಿಗ್ಮಾಯ್ಡಾಸ್ಟಮಿ. ಓಕೆ, ಸ್ಟ್ರೆಪ್ಟೋಕಾಕಸ್ ಬಾವಿಸ್ ಇಂದ ಇನ್ಫೆಕ್ಟ್ ಆಗಿದ್ರೆ ದ್ಯಾಟ್ ಕ್ಯಾನ್ ಆಲ್ಸೋ ಇನ್ಕ್ರೀಸ್ ದ ರಿಸ್ಕ್ ಆಫ್ ಅಡಿನೋಮ್ಯಾಟಸ್ ಪಾಲಿಪ್ ಆ್ಯಂಡ್ ಆಕ್ರೋಮೆಗಾಲಿ. ಓಕೆ, ದ ಫ್ಯಾಕ್ಟರ್ಸ್ ವಿಚ್ ಇನ್ಕ್ರೀಸ್ ರಿಸ್ಕ್ ಆಫ್ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ. ಸೊ ಅಡಿನೋಮ್ಯಾಟಸ್ ಪಾಲಿಪ್ ಇನ್ಕ್ರೀಸ್ ಮಾಡೋದು ಒಂದಷ್ಟು ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ಇದೆ. ಅಡಿನೋಮ್ಯಾಟಸ್ ಪಾಲಿಪ್ ಆಗಿ ಅದರಿಂದ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ ಕಾಸ್ ಮಾಡೋಷ್ಟು ಒಂದಷ್ಟು ಫ್ಯಾಕ್ಟರ್ಸ್ ಇದೆ. ದೇ ಆರ್ ವಿಲ್ಲಸ್ ಪಾಲಿಪ್, ಅದು ಮ್ಯಾಕ್ಸಿಮಮ್ ಗೊತ್ತಲ್ಲ, ಮ್ಯಾಕ್ಸಿಮಮ್ ಮೋಸ್ಟ್ ಕಾಮನ್ ಮ್ಯಾಲಿಗ್ನೆಂಟ್, ದಟ್ ಈಸ್ ವಿಲ್ಲಸ್. ಆಫ್ಟರ್ ದಟ್ ಸೆಸೈಲ್ ಪಾಲಿಪ್. ಸೆಸೈಲು ಪೆಂಡುಲೇಟೆಡ್, ಎರಡು ಥರ ಬರುತ್ತೆ. ಸೆಸೈಲ್ ಅಂದರೆ ವಿಚ್ ಇಸ್ ಟೈಟ್ಲಿ ಅಡರೆಂಟ್ ಟು ದ ಮ್ಯೂಕೋಸಾ. ಇವಾಗ ಇದು ಕೊಲಾನಿಕ್ ಮ್ಯೂಕೋಸಾ ಅಂತಿದ್ರೆ ಇಟ್ ಈಸ್ ಟೈಟ್ಲಿ ಅಡರೆಂಟ್. ಪೆಂಡುಲೇಟೆಡ್ ಇದ್ದರೆ there will be a stalk, after that there will be a polyp. So this type is called as sessile, and these are more risky for formation of malignancy, okay, than pendulated ones. And if the size of the polyp is more than 2 cm, again it is a risk factor for malignancy. So there are two main syndromes that is associated with adenomatous polyp, that is familial adenomatous polyposis and hereditary non-polyposis colorectal cancer. These are the two most important topics from today's class. If you know about this, then we can easily know about colorectal cancer, and then manageable, we can score well. Okay, so what are these two? FAP, or familial adenomatous polyposis. This is responsible for 1% of colorectal cancer in population, and it is very important because there is 100% risk of malignancy. If a person develops this FAP, then for sure he'll go for colorectal cancer. Okay, HNPCC, hereditary non-polyposis. This is responsible for 5% of colorectal cancer in population, but it has up to 80% risk of malignancy. So basically, if the person is having colorectal cancer, it is either because of these two conditions. You can say this. Okay, hence these two conditions we have to study to know about colorectal cancer. So starting with familial adenomatous polyposis. So familial adenomatous polyposis, it is a genetic condition. It is an autosomal dominant. If a father or mother is having, then definitely child will have it. That is what it means by autosomal dominant. Every generation will have this. Okay, what is a mutated gene here? That is APC, adenomatous polyposis coli gene. Okay, this gene is located on chromosome 5q, that is long arm 21 is a loci. It is characterized by more than 100 adenomatous polyps. So you can imagine, throughout the GIT there is more than 100 polyps. Okay, so this will obviously lead to cancer, that is colorectal cancer. So more than 100 adenomatous polyps ಇದೆ, and they are associated with 100% risk of malignancy. The polyp formation begins at the age of 15 years. ಆಯಿತಾ, ಒನ್ ಪಾಲಿಪು ಮೇ ಬಿ 15 ಇಯರ್ಸಿಗೆ ಶುರು ಆಗ್ಬೋದು, ಬಟ್ ಬೈ 40 years of age, ಅಂದರೆ 25 ವರ್ಷದಲ್ಲಿ patient 100% patients will develop malignancy. So what will be the clinical feature? Obviously polyp ಅಂದರೆ there will be bleeding per rectum. And investigations ಏನಿರ್ಬೋದು, it can involve any part of the GIT. On digital rectal examination or proctoscopy, we can see the polyp, and investigation of choice to say that this is familial adenomatous polyposis, you can say colonoscopy is the investigation of choice, like visualizing it. And more than 100 polyps, if we are able to visualize and we take a biopsy of that and we see it under microscope, we will be able to see numerous glands. Adeno means glands. Okay, so increased number of glands will suggest that it is adenomatous variety of polyp. So So more than 100 polyps on colonoscopy, and on histology, if adenomatous variety of polyp is seen, then we can say that it is familial adenomatous polyposis. Other than that, we can go for genetic studies also to identify that APC gene mutation ಇದೆ ಇದರಲ್ಲಿ, that and all we can do. Okay, and we can rule out by history also if it is autosomal dominant or not. So other than that, investigations, these two investigations can be done. So after diagnosing that this is FAP, what is the treatment? We have to go for total proctocolectomy. Entire large intestine has to be removed, and then ileum will be remaining because it's a part of small intestine, and some part of the anal canal we have to retain it, and then ileum and anal canal is anastomosed. So ileal pouch, anal anastomosis, that is IPAA. Okay, IPAA, this is in short form called as IPAA. So TPC, that is total proctocolectomy, and ileal pouch, anal anastomosis. This is the definitive treatment or treatment of choice for FAP. Okay, so most commonly even after this treatment, if the patient dies, that will be because of periampullary carcinoma of pancreas. Okay, so GIT ಇಂದ pancreatic spread ಆಗಿ, because GIT ಇದೆ, ಅದರ ಕ್ಲೋಸ್ ಅಸೋಸಿಯೇಷನ್ ಅಲ್ಲಿ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಇದೆ in the second part of the duodenum. So probably this will spread to the periampullary region of pancreas, and that will cause death in these patients. Okay, so complication ಏನಾಗುತ್ತೆ, if we remove entire large intestine, then there will be most common complication will be small bowel obstruction in case of 25% cases. What is remaining is small bowel. If that goes for obstruction, because of ಸೀದಾ anal canal ಗೆ ಕನೆಕ್ಟ್ ಆಗ್ತದೆ, ಅಲ್ಲಿಂದ ಕೊಲಾನ್ಗೆ ಹೋಗಿಲ್ಲ, ಸೊ ಬಿಕಾಸ್ ಆಫ್ ದ್ಯಾಟ್ ದೇರ್ ಇಸ್ ನೋ ವ್ಯಾಲ್ವ್. ಸೊ ವಾಟ್ ಎವರ್ ದ ಫುಡ್ ಇಸ್ ದೇರ್, ದಟ್ ವಿಲ್ ಡೈರೆಕ್ಟ್ಲಿ ಕಮ್ ಇನ್ ಟು ದ ಸ್ಮಾಲ್ ಇಂಟೆಸ್ಟೈನ್ and then into the anal canal. Because of like we won't pass stools that often. If large intestine was there, that had a maximum caliber capacity, so food and feces would have been stored there. Here there is no such space, and we won't pass stools that frequently. So because of that reason, there can be small bowel obstruction in 25% cases. And pouchitis, that is ileal pouch create ಮಾಡಿರ್ತೀವಿ, ಅದ್ರದ್ದು ಇನ್ಫ್ಲಮೇಷನ್ ಆಗ್ಬೋದು, that can lead to pouchitis. Usually this is not seen in FAP, but it is seen in case of inflammatory bowel disease, that is ulcerative colitis, pouchitis, and small bowel obstruction is common. Okay, so after this, screening. So how can we screen? Since we know this is a genetic disease and it is an autosomal dominant condition, we can do something to prevent this before happening alla. So what we'll do, FAP is an autosomal dominant, so 50% of the patient's family members can have FAP, so screening should be done. Okay, investigation of choice for screening of the family members of FAP is APC gene testing. ಸೊ ಇವಾಗ 2 ಪೇರೆಂಟ್ಸ್ ಇದ್ದಾರೆ, ಅವರಲ್ಲಿ ಒಬ್ಬರಿಗೆ FAP ಇದೆ ಅಂತ ಅನ್ಕೊಳ್ಳೋಣ. ಇಫ್ ದೇ ಹ್ಯಾವ್ 4 kids, we know that 2 of them are definitely going to have FAP. Okay, for that reason we can go for screening, and then we can do something by early detection. If the mutation for this APC gene is positive, then surveillance is done by colonoscopy. So ಪ್ರತಿ ವರ್ಷ ಇಯರ್ಲಿ ಬಂದು colonoscopy ಮಾಡಿಸ್ಕೊಂಡು we can treat them. If polyp is detected, then we will go for total proctocolectomy if recommended. Okay, early treatment will be initiated if we get to know it beforehand. So that's the reason we will go for screening. Okay, so there are 2 varieties of FAP, that is familial adenomatous polyposis ಅಲ್ಲಿ 2 ವೆರೈಟಿ. ಒಂದು ಗಾರ್ಡ್ನರ್ಸ್ ಸಿಂಡ್ರೋಮ್, ಅದರ್ ಒನ್ ಇಸ್ ಟರ್ಕೋಟ್ಸ್ ಸಿಂಡ್ರೋಮ್. ಸೊ ಗಾರ್ಡ್ನರ್ಸ್ ಸಿಂಡ್ರೋಮ್ ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಇಟ್ ಈಸ್ ಅ ಆಟೋಸೋಮಲ್ ಡಾಮಿನೆಂಟ್ ಕಂಡೀಷನ್ ಅಗೇನ್, ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಅಸೋಸಿಯೇಟೆಡ್ ವಿತ್ ಅಲಾಂಗ್ ವಿತ್ ದಿಸ್ ಪಾಲಿಪ್ಸ್ ಏನು ನಾವು ನೋಡ್ತಿದ್ದೀವಿ ಅಡಿನೋಮ್ಯಾಟಸ್ ಪಾಲಿಪ್ಸು, ಅದ್ರ ಜೊತೆಗೆ ದೇರ್ ವಿಲ್ ಬಿ ಅಸೋಸಿಯೇಟೆಡ್ ಸಮ್ ಅದರ್ ಕಂಡೀಷನ್ಸ್ that will form a syndrome. Okay, if there is bone, that is bone tumor, that is osteoma in mandible, usually most common. ಅದರ ಜೊತೆಗೆ congenital hypertrophied retinal pigment epithelium, so eye is also involved, bone is involved. Then desmoid tumors, sebaceous cyst, benign lymphoid polyposis of ileum, and supernumerary teeth, that is extra teeth. All these things are involved, then that constitutes a syndrome called as Gardner's syndrome. Other one is Turcotte's. Irrespective of this familial adenomatous polyposis, it is an autosomal recessive condition in which along with FAP there will be associated brain tumors. Okay, so this Turcotte's syndrome, it will have adenomatous polyp plus brain tumor ಆಯ್ತಾ. So this adenomatous polyp can be FAP or it can be due to HNPCC, and along with that there will be a brain tumor. So this is Turcotte syndrome. If FAP is the most common brain tumor associated will be usually medulloblastoma. But in case of HNPCC, if there is a brain tumor, that will be glioblastoma multiforme. So this will be appearing from glial cells. Okay, basically glioma stage 4 is called as glioblastoma multiforme. So ಇದು medulloblastoma. Okay, ependymal cells ಇಂದ ಬರ್ತಿರುತ್ತೆ. So this was about FAP. So we have discussed about FAP introduction, ಅದಾದ್ಮೇಲೆ ಕ್ಲಿನಿಕಲ್ ಪ್ರೆಸೆಂಟೇಷನ್, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ ಏನು ಬೇಕು, ಟ್ರೀಟ್ಮೆಂಟ್, ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಫ್ ದ ಸರ್ಜರಿ, ದೆನ್ ಸ್ಕ್ರೀನಿಂಗ್ ಹೆಂಗೆ ಮಾಡ್ಬೋದು, ದೆನ್ ವೇರಿಯಂಟ್ಸ್ ಆಫ್ FAP. ಓಕೆ, ಸೊ ನಾವು ವಿಲ್ ಸ್ಟಾರ್ಟ್ ವಿತ್ next polyp, that is hereditary non-polyposis colorectal cancer. This is also a reason for adenomatous polyps, and these adenomatous polyps are neoplastic. Okay, so again, just like FAP, HNPCC is also autosomal dominant, so 50% of offsprings or children will have this disease. Okay, this is caused by mismatch repair gene abnormality. So ಇವಾಗ ನಮ್ಮ ಬಾಡಿಯಲ್ಲಿ ಒಂದು ಜೀನ್ ಇದೆ ವಿಚ್ ವಿಲ್ ಐಡೆಂಟಿಫೈ ಮಿಸ್ಮ್ಯಾಚ್ ರಿಪೇರ್. ಸೊ ಮಿಸ್ಮ್ಯಾಚ್ ರಿಪೇರ್ ಮಾಡೋಕ್ಕೆ ಅಂತಲೇ ಒಂದು ಜೀನ್ ಇದೆ. ಆ ಜೀನಲ್ಲೇ ಮ್ಯೂಟೇಷನ್ ಆಯ್ತಂದರೆ there will be no one supervising this mismatch. So because of that reason we'll start developing all these polyps. So in this case there can be 3 chromosomes involved, that is chromosome 2, 3 and 7, and there are 7 genes involved. In more than 90% of the cases these 2 genes are involved, that is MLH1 and MSH2. Okay, in case of FAP it was APC gene. In case of this HNPCC it is MLH1 and MSH2 genes. Okay, what criteria do we use to diagnose is modified Amsterdam criteria. There is also a revised Bethesda criteria which is used for detecting microsatellite instability. Okay, these just like we have discussed before, HNPCC is responsible for 5% of colorectal cancer in the population and up to 80% risk of malignancy. FAP is 1% but 100% risk of malignancy. Okay, so HNPCC is also known by other name, that is Lynch syndrome. Okay, now this Lynch syndrome can be of Lynch 1 or Lynch 2, two types. So Lynch 1 ಅಂದರೆ ಬರೀ colorectal cancer cause ಮಾಡುತ್ತೆ. Lynch 2 ಅಂದರೆ colorectal cancer along with that some extra intestinal malignancy will be there, that is like endometrial malignancy along with colorectal cancer, or gastric malignancy and colorectal cancer, or ovarian malignancy and colorectal cancer, that is Lynch 2. Okay, there is one more syndrome that is associated with HNPCC other than Turcotte, that is Muir-Torre syndrome. ಇಲ್ಲೇನಾಗುತ್ತೆ, ಇಟ್ ಈಸ್ ಕ್ಯಾರೆಕ್ಟರೈಸ್ಡ್ ಬೈ ಬಿನೈನ್ ಅಂಡ್ ಮ್ಯಾಲಿಗ್ನೆಂಟ್ ಟ್ಯೂಮರ್ ಆಫ್ ಸೆಬೇಷಿಯಸ್ ಗ್ಲ್ಯಾಂಡ್ ಆ್ಯಂಡ್ ಕೆರಾಟೋಕ್ಯಾಂಥೋಮಾ. ಸೊ ಬೇಸಿಕಲಿ ಸ್ಕಿನ್ ಪ್ಲಸ್ GI, ಬಟ್ ದಿಸ್ ಇಸ್ ನಾಟ್ ಪ್ಯೂರ್ಸ್ ಜಿಗರ್, ದಟ್ ಈಸ್ ಮುಯಿರ್-ಟಾರ್. ಓಕೆ, ಸೊ ಇದಾದಮೇಲೆ HNPCCನ ಹೆಂಗೆ ಮ್ಯಾನೇಜ್ ಮಾಡ್ತೀವಿ. ಸೊ HNPCC ಅಗೇನ್ ವಿಲ್ ಸಿ ನ್ಯೂಮರಸ್ ಪಾಲಿಪ್ಸ್ ಆರ್ ನಾನ್ ಪಾಲಿಪೋಸಿಸ್. ಪಾಲಿಪ್ ಕಾಣಿಸಲ್ಲ ಬಟ್ ದೇರ್ ವಿಲ್ ಬಿ ಮ್ಯೂಟೇಷನ್. ಓಕೆ, ಸೊ ಸರ್ವೈಲೆನ್ಸ್ ಕೊಲೊನೋಸ್ಕೋಪಿ should be started at 20 years. If patient develops CA colon, then we will go for total colectomy along with that ileorectal anastomosis. But rectum has high risk of malignancy, that is hence we will go for annual proctoscopy to detect malignancy. For females who have completed their family prophylactic treatment, that is transabdominal hysterectomy and bilateral salpingo-oophorectomy in order to prevent extraintestinal manifestations. So this is the management. ಬೇಸಿಕಲಿ ಕೊಲೋನೋಸ್ಕೋಪಿ ಮಾಡ್ತಾ ಇರಬೇಕು ಸ್ಕ್ರೀನ್ ಮಾಡೋಕ್ಕೆ ಫಾರ್ HNPCC. ಸ್ಕ್ರೀನ್ ಮಾಡಿ ಇಫ್ ದ ಪೇಷಂಟ್ ಡೆವಲಪ್ಸ್ CA colon, then we will have to remove entire colon and ileum will be remaining, that will be anastomosed with rectum. ಓಕೆ, ಅದಾದಮೇಲೆ ಇಲಿಯೋರೆಕ್ಟಲ್ ಅಂದರೆ ಟೋಟಲ್ ಕೊಲೆಕ್ಟಮಿ ಮಾಡಾಗಿದೆ, ಮತ್ತೆ ಇವರಿಗೆ ಪ್ರಾಬ್ಲಮ್ ಆಗಲ್ಲ ಬಿಡು ಅಂತ ಬಿಡೋಂಗಿಲ್ಲ, ಬಿಕಾಸ್ ಅಗೇನ್ ವಾಟ್ ಎವರ್ ದ ರೆಕ್ಟಮ್ ವಿ ಹ್ಯಾವ್ ಲೆಫ್ಟ್ ಇಟ್ ಔಟ್, ದ್ಯಾಟ್ ಕ್ಯಾನ್ ಡೆವಲಪ್ malignancy. Okay, and for that reason even after total colectomy and ileorectal anastomosis we will have to go for annual proctoscopy. Okay, and for females abdominal hysterectomy and bilateral salpingo-oophorectomy is done. So after this, how can we screen for colorectal cancer? Usually if the this screening for colorectal cancer will start after 50 years of age. Okay, the first one is fecal occult blood test. So this should be performed annually after 40 years of age in order to screen for colorectal cancers. After this, we'll go for flexible sigmoidoscopy, that is performed every 5 years. Okay. After that, double contrast barium enema we can perform, that will be performed usually every 10 years once. In colonoscopy every 10 years. So most preferred is colonoscopy as it is non-invasive and it is contraindicated. If colonoscopy is contraindicated, then we'll have to go for double contrast barium enema. So this is how the screen for colorectal cancers. Okay, so what are the risk factors for colorectal cancer? Number one causes smoking, alcohol, high fat diet, and other two neoplastic polyps. Other than this, adenomatous polyp again, then uterosigmoidostomy, whatever we have discussed for USA, that is uterosigmoidostomy, streptococcus bovis bacteremia, and acromegaly. Other than that, inflammatory bowel diseases, not inflammatory polyp but inflammatory bowel diseases, and if there is any pelvic irradiation, then they are the risk factors for developing colorectal cancer. Okay, again colorectum, that is colon and rectum, we are studying it together because they have similar risk factors and manifestations, but CA rectum will be dealt in rectum and anal canal as a separate class. Now we will discuss CA colon. Okay, so what is the now starting with CA colon. Most common site for CA colon is sigmoid, that is the last part. Okay, before rectum and anal canal, whatever the part is remaining, that is the most common site for CA colon. And least common site is hepatic flexure. Most common site for metastasis being hematogenous spread ಆಗುತ್ತೆ, ಅದಕ್ಕೆ ಲಿವರಿಗೆ ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ಸ್ಪ್ರೆಡ್ ಆಗುತ್ತೆ, ಆಮೇಲೆ ಲಂಗ್ಸಿಗೆ ಹೋಗುತ್ತೆ. ಓಕೆ, ಸೊ ಇದೊಂದು ರೆಜಿಮನ್ ಇವಾಗಲೇ ಹೇಳಿರ್ತೀನಿ, ಜಸ್ಟ್ ಟ್ರೈ ಟು ರಿಮೆಂಬರ್. ಫಾಲ್ ಫಾಕ್ಸ್ ರೆಜಿಮ್ ಅಂತ ಕರೀತಾರೆ. ದಿಸ್ ಇಸ್ ಅ ಕೀಮೋಥೆರಪಿ ರೆಜಿಮ್ ವಿಚ್ ವಿ ಯೂಸ್ ಫಾರ್ ಟ್ರೀಟಿಂಗ್ ಸಿಎ ಕೊಲಾನ್. ಫಾಲ್ ಫಾಕ್ಸ್ ಅಲ್ಲಿ ದಿಸ್ ಇಸ್ ಅ ನಿಮೋನಿಕ್. ಫಾಲ್ ಮೀನ್ಸ್ ಫೋಲಿನಿಕ್ ಆಸಿಡ್ ಆರ್ ವಿ ಕ್ಯಾನ್ ಸೇ ಲ್ಯೂಕೋವರಿನ್, and F stands for 5-fluorouracil and OX stands for oxaliplatin. This Folfox IV is preferred for CA colon and CA rectum, and Folfiri, this was earlier used, that is folinic acid, 5-fluorouracil and irinotecan was used. Now this irinotecan is not used and oxaliplatin is used, and this is used for both CA colon and CA rectum. Okay, so CA colon, idralli ಏನಿರುತ್ತೆ clinical features, how will the patient come to us? So most common symptom will be usually abdominal pain. There is a tumor. Okay, most common symptom will be abdominal pain. After that, right iliac fossa mass and alteration in the bowel habit, this can happen. After that, there can be hematochezia and melena, passage of blood in stools basically. Adadmele blood, there can be ಈ CA colon ಆದರೆ ಬೇಸಿಕಲಿ ಏನಾಗುತ್ತೆ ಅಂದರೆ there is a tumor growing in the colon. Okay, so tumor ಇದಾದರೆ ಏನಾಗುತ್ತೆ, there will be disruption of the mucosa also. Because of this reason there will be bleeding. ಆಯ್ತಾ, if this bleeding, if there it is there in the sigmoid, we can see fresh bleeding also. Otherwise, whatever this bleeding is there, that can be stored here and that will be passed along with stools. Okay, so if it is stored there and passed along with stools, that will appear like hematochezia or melena. Or if there is continuous bleeding happening and we are not noticing anything, then that patient can go for anemia, because there is somewhere internal bleeding is happening and continuously HB is dropping. So because of that reason, patient will be experiencing fatigue. So this is the clinical manifestations, and the symptoms will differ depending upon the location. If it is right colonic or left colonic, right colonic is ascending colon, left colonic is descending colon. Okay, so right colonic malignancy ಅಲ್ಲಿ ಏನಿರುತ್ತೆ, it will be fungating or cauliflower like growth, ಹಿಂಗಿರುತ್ತೆ growth. Okay, colon ಅಲ್ಲಿ, and usually liquid fecal matter will be there. Most common symptom being bleeding and melena, which will in turn will lead to anemia and fatigue. And usually right colonic ಆಗಿರೋದ್ರಿಂದ right iliac fossa ದಲ್ಲಿ ಮಾಸ್ ಇರುತ್ತೆ. In advanced cases, ಇದು ಫೈನಲ್ ಸ್ಟೇಜ್ಗೆ ಹೋದಾಗ ಮಾಸ್ ಫೀಲ್ ಆಗುತ್ತೆ ನಮಗೆ, ಅಲ್ಲಿವರೆಗೂ ಫೀಲ್ ಆಗಲ್ಲ ಯೂಶಲಿ. ಸೊ ಲೆಫ್ಟ್ ಕೊಲೋನಿಕ್ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ ಇಟ್ ವಿಲ್ ಬಿ ಆ್ಯನ್ಯುಲರ್ ಆರ್ ಸ್ಟಿನೋಸಿಂಗ್ ಗ್ರೋತ್. ಸೊ ಇಲ್ಲಿ ಕಾಲಿಫ್ಲವರ್ ಆರ್ ಫಂಗೇಟಿಂಗ್ ಗ್ರೋತ್ ಇತ್ತು, ಇಲ್ಲಿ ಆ್ಯನ್ಯುಲರ್ ಆರ್ ಸ್ಟಿನೋಸಿಂಗ್ ಗ್ರೋತ್ ಇರುತ್ತೆ. ಆ್ಯಂಡ್ ಸಾಲಿಡ್ ಫೀಕಲ್ ಮ್ಯಾಟರ್ ಇರುತ್ತೆ, ಲಿಕ್ವಿಡ್ ಏನಿರುತ್ತೆ ಎಲ್ಲ ಅಬ್ಸರ್ವ್ ಆಗಿರುತ್ತೆ. ಓಕೆ, ಆ್ಯಂಡ್ ನ್ಯಾರೋ ಕ್ಯಾಲಿಬರ್ ಇರುತ್ತೆ ಬಿಕಾಸ್ ಇಟ್ ಇಸ್ ಅ ಸ್ಟಿನೋಸಿಂಗ್ ಟೈಪ್ ಆಫ್ ಗ್ರೋತ್. ಇಟ್ ವಿಲ್ ಬಿ ಡಿಕ್ರೀಸಿಂಗ್ ದ ಲುಮೆನ್. ಆ್ಯಂಡ್ ಮೋಸ್ಟ್ ಕಾಮನ್ ಸಿಂಪ್ಟಮ್ ಏನಿರುತ್ತೆ, ಅಬ್ಡಾಮಿನಲ್ ಪೇನ್ ಇರುತ್ತೆ ಬಿಕಾಸ್ ಆಫ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್. ಓಕೆ, ದ ಮೋಸ್ಟ್ ಕಾಮನ್ ಸಿಂಪ್ಟಮ್ ಆಫ್ ಸಿ ಎ ಟ್ರಾನ್ಸ್ವರ್ಸ್ ಕೊಲಾನ್ ಏನಿರುತ್ತೆ, ಬ್ಲೀಡಿಂಗ್ ಆ್ಯಂಡ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್. ಇದು ರೈಟ್ ಕೊಲಾನಿಕ್ ಆಯಿತು, ಲೆಫ್ಟ್ ಕೊಲಾನಿಕ್ ಆಯಿತು, ಮಧ್ಯದಲ್ಲಿರೋದು ಟ್ರಾನ್ಸ್ವರ್ಸ್ ಕೊಲಾನ್. ಇನ್ ದ್ಯಾಟ್ ಕೇಸ್ ದೇರ್ ವಿಲ್ ಬಿ ಬ್ಲೀಡಿಂಗ್ ಆ್ಯಂಡ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್. ಓಕೆ, ಸೊ ಹೌ ವಿಲ್ ವಿ ಡಯಾಗ್ನೋಸ್ ಇಟ್? ಡಯಾಗ್ನೋಸಿಸ್ ಆಬ್ವಿಯಸ್ಲಿ ವಿಜುವಲೈಸ್ ಮಾಡಬೇಕು. ಕೊಲೋನೋಸ್ಕೋಪಿಯಲ್ಲಿ ಏನೋ ಒಂದು ಮಾಸ್ ಕಾಣಿಸುತ್ತೆ ಅಂತ ಅನ್ಕೊಳ್ಳೋಣ ಕೊಲಾನಲ್ಲಿ, ಅದನ್ನು ಬಯೋಪ್ಸಿ ತೆಗಿತೀವಿ. ಅದ್ರ ಬೇಸ್ ಮೇಲೆ ಹಿಸ್ಟೋಪ್ಯಾಥಾಲಜಿ ಮಾಡಿ ವಿ ಕ್ಯಾನ್ ಕನ್ಫರ್ಮ್ ಇಟ್ ಇಫ್ ಇಟ್ ಈಸ್ ಸಿ ಎ ಕೊಲಾನ್ ಆರ್ ನಾಟ್. ಸ್ಟೇಜ್ ಮಾಡಬೇಕು ಅಂದರೆ ಯಾವ ಸ್ಟೇಜಲ್ಲಿದೆ ಕ್ಯಾನ್ಸರ್ ಅಂತ ಗೊತ್ತಾಗಬೇಕಂದ್ರೆ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ CECT ಟು ಸಿ ವೇರ್ ಎವರ್ ಇಟ್ ಹ್ಯಾಸ್ ಸ್ಪ್ರೆಡ್. ಸೊ ಸ್ಟೇಜಿಂಗ್ ಈಸ್ ಬೈ contrast enhanced CT scan. So we use criteria or classification criteria called as modified Dukes or modified Ashler-Collar classification. Okay, ಇದರಲ್ಲಿ ಏನು ಹೇಳುತ್ತೆ, ಅಕಾರ್ಡಿಂಗ್ ಟು ದಿಸ್ ಸ್ಟೇಜ್ ಎ ಅಂದರೆ ಟ್ಯೂಮರ್ ಈಸ್ ಜಸ್ಟ್ ಕನ್ಫೈನ್ಡ್ ಟು ಮ್ಯೂಕೋಸಾ, ಮೇಲ್ಗಡೆ ಮಾತ್ರ ಇದೆ. ಇನ್ ಸ್ಟೇಜ್ ಆರ್ B1 ಅಂತ ಕ್ಲಾಸಿಫೈ ಮಾಡಿದ್ದಾರೆ. ಅದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ದೆರ್ ವಿಲ್ ಬಿ ಪಾರ್ಷಿಯಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆಫ್ ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ. ಸೊ ಮ್ಯೂಕೋಸಾ ಜೊತೆಗೆ ಪಾರ್ಷಿಯಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆಫ್ ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ ಆಗಿದೆ. ಓಕೆ, B2 ಫುಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆಫ್ ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ. ಸೊ ಇವಾಗ ಇಷ್ಟು ರೀಜನ್ನು ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ. ಪಾರ್ಷಿಯಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆದರೆ B1, ಕಂಪ್ಲೀಟ್ ಪೆನಿಟ್ರೇಷನ್ ಆದರೆ B2. ಓಕೆ, ಸೊ C1 ದಟ್ ಈಸ್ ಪಾರ್ಷಿಯಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆಫ್ ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ ಅಲಾಂಗ್ ವಿತ್ ದಟ್ ಲಿಂಫ್ ನೋಡ್ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್. ಸೊ ಪಾರ್ಷಿಯಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆಗಿದೆ, ಅದ್ರ ಜೊತೆಗೆ ಲಿಂಫ್ ನೋಡ್ ಇನ್ವಾಲ್ವ್ ಆಗಿದೆ. ಇನ್ ದ್ಯಾಟ್ ಕೇಸ್ ಇಟ್ ಈಸ್ C1. C2 ಈಸ್ ಅಗೇನ್ ಫುಲ್ ಪೆನಿಟ್ರೇಷನ್ ಆಫ್ ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ ಪ್ಲಸ್ ಲಿಂಫ್ ನೋಡ್ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್. D ಈಸ್ ಡಿಸ್ಟೆಂಟ್ ಮೆಟಾಸ್ಟಾಸಿಸ್, ದಟ್ ಈಸ್ ಲಿವರ್ಗೋ ಲಂಗ್ಸ್ಗೋ ಸ್ಪ್ರೆಡ್ ಆಗಿರುತ್ತೆ. ಓಕೆ, ಈಸಿ ಇದೆ ಅಲ್ವಾ? ಸೊ ಬೇಸ್ಡ್ ಆನ್ ದಿಸ್ ಯು ಕ್ಯಾನ್ ಸೇ ಅಗೇನ್ AJCC ಆರ್ UICC ಅಂತ ಇದ್ದಿದ್ದು ಅಮೇರಿಕನ್ ಜಾಯಿಂಟ್ ಅಸೋಸಿಯೇಷನ್. ಇವ್ರೇನು ಮಾಡಿದ್ದಾರೆ, ಇವಾಗ ಬೇಸಿಕಲಿ ಇದರಲ್ಲಿ ಸಿಂಪಲ್ ಆಗಿದೆ. ಸೊ ಇದರಲ್ಲಿ ಅರ್ಥ ಮಾಡ್ಕೋಣ. ಸ್ಟೇಜ್ 1 ಅಂದರೆ ಇಟ್ ಕ್ಯಾನ್ ಬಿ A and B1, ದಟ್ ಈಸ್ ಪಾರ್ಷಿಯಲ್, or you can say tumor will be confined to mucosa, or there will be partial involvement penetration of muscularis propria. If there is complete penetration of muscularis propria or that is involvement of serosa, then that will be stage 2. Stage 3 ಅಂದರೆ C1, C2, C3 ಮೂರೂ, that is along with lymph node involvement there will be partial or complete penetration of muscularis propria. Stage 4 is distant metastasis. Similarly, they have given TNM staging. Carcinoma in situ or only invasion of lamina propria. If the tumor invades submucosa, then it is T1. If it invades muscularis propria, T2. Along with that, subserosa or into peritoneal, peritonealized pericolic or perirectal tissues, then it is T3. T4A ಅಂದರೆ it penetrates the surface of visceral peritoneum. T4B directly invades or is adherent to other structures. ಬೇಸಿಕಲಿ ಎಷ್ಟು ಡೆಪ್ತಲ್ಲಿ ಹೋಗ್ತಾ ಇದೆ ಟ್ಯೂಮರ್ ಅನ್ನೋದ್ರ ಬೇಸ್ ಮೇಲೆ ಸ್ಟೇಜಿಂಗ್ ಇರುತ್ತೆ. ಇಷ್ಟು ಗೊತ್ತಿದ್ರೆ ಸಾಕು. N1 ಅಂದರೆ 1 to 3 ರೀಜನಲ್ ಲಿಂಫ್ ನೋಟ್ಸು. N1A ಮೆಟಾಸ್ಟಾಸಿಸ್ ಟು ಓನ್ಲಿ 1. ಇಫ್ 2 or 3 is there, then N1B. N1C ಅಂದರೆ ಟ್ಯೂಮರ್ ಡೆಪಾಸಿಟ್ಸ್ ಇನ್ ಸಬ್ಸಿರೋಸಾ, ಮಿಸೆಂಟ್ರಿ ಆರ್ ನಾನ್ ಪೆರಿಟೋನಿಯಲೈಸ್ ಪೆರಿಕೋಲಿಕ್ ಆರ್ ಪೆರಿರೆಕ್ಟಲ್ ಟಿಶ್ಯೂಸ್. N2A is again more than 3, that is 4 to 6. N2B is more than 7. M1A ಅಂದರೆ ಮೆಟಾಸ್ಟಾಸಿಸ್, ಬಟ್ ಇಟ್ ಈಸ್ ಕನ್ಫೈನ್ಡ್ ಟು ಓನ್ಲಿ ಒನ್ ಆರ್ಗನ್, ಲಿವರ್ ಆರ್ ಲಂಗ್ಸ್. And site is without peritoneal metastasis. M1B ಅಂದರೆ metastasis to more than one organ. M1C is peritoneum is also involved. So based on this we will stage. That was TNM staging. ನಮಗೆ ಆ TNM staging ಅಲ್ಲ ಇಂಪಾರ್ಟೆಂಟು. TNM ಮೂರನ್ನು ಸೇರಿಸಿ ಲಾಸ್ಟಿಗೆ ಒಂದು ಫೈನಲ್ ಸ್ಟೇಜ್ ಬರುತ್ತೆ. That staging is important, which we are discussing now. Okay, tumor in situ ಇದ್ದರೆ we'll just remove that polyp or whatever the growth is there. ಆಯಿತಾ, ಅಷ್ಟೇ ಟ್ರೀಟ್ಮೆಂಟು, ಪಾಲಿಪೆಕ್ಟಮಿ ಅಷ್ಟೇ. ಸ್ಟೇಜ್ 1 and 2, 1 and 2 ಇನ್ವಾಲ್ವ್ ಆಗಿದ್ರೆ ಏನಾಗಿರುತ್ತೆ, ಐದರ್ ಮಸ್ಕ್ಯುಲಾರಿಸ್ ಪ್ರಾಪ್ರಿಯಾ ವಿಲ್ ಬಿ ಪಾರ್ಷಿಯಲಿ ಆರ್ ಟೋಟಲಿ ಇನ್ವೇಡೆಡ್. ಇನ್ ದ್ಯಾಟ್ ಕೇಸ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ದ್ಯಾಟ್ ಸೆಗ್ಮೆಂಟ್ ರಿಸೆಕ್ಷನ್. ಸ್ಟೇಜ್ 3 ಆಗಿದ್ರೆ ಸೆಗ್ಮೆಂಟ್ ರಿಸೆಕ್ಷನ್ ಅಲ್ಲದೆ, ಸಿನ್ಸ್ ಸಿರೋಸಾ ಆರ್ ಎನಿಥಿಂಗ್ ಮೈಟ್ ಬಿ ಇನ್ವಾಲ್ವ್, ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಕೀಮೋಥೆರಪಿ, ದಟ್ ಈಸ್ ಫಾಲ್ಫಾಕ್ಸ್, ಫೋಲಿನಿಕ್ ಆ್ಯಸಿಡ್ ಆರ್ ಲ್ಯೂಕೋವರಿನ್ ಆ್ಯಂಡ್ 5-fluorouracil ಆ್ಯಂಡ್ ಆಕ್ಸಾಲಿಪ್ಲಾಟಿನ್. ಅವು ಮೂರದು ರೆಜಿಮೆನ್ ಕೊಡಬೇಕಾಗುತ್ತೆ. ಸ್ಟೇಜ್ 4 ಅಂದರೆ ಡಿಸ್ಟೆಂಟ್ ಮೆಟಾಸ್ಟಾಸಿಸ್ ಆಗೋಗಿದೆ. ಸೊ ಮೆಟಾಸ್ಟಾಸಿಸ್ ಎಲ್ಲಾಗಿದೆ ಆ ರೀಜನಲ್ಲಿ ಟ್ಯೂಮರ್ ಎಲ್ಲಿ ಕಾಣಿಸಿದ್ರೆ ಅದನ್ನು ಎಕ್ಟಮಿ, ಮೆಟಾಸ್ಟಾಸೆಕ್ಟಮಿ. ಅಲಾಂಗ್ ವಿತ್ ದಟ್ ನಥಿಂಗ್ ಎಲ್ಸ್ ಕ್ಯಾನ್ ಬಿ ಡನ್, ವಿಲ್ ಹ್ಯಾವ್ ಟು ಜಸ್ಟ್ ಗೋ ಫಾರ್ ಪ್ಯಾಲಿಯೇಟಿವ್. ಎಷ್ಟು ದಿನ ಇರ್ತಾರೆ ಅಷ್ಟು ದಿನ ಚೆನ್ನಾಗಿ ನೋಡ್ಕೋಬೇಕು ಅಷ್ಟೇ. ಮೋಸ್ಟ್ ಕಾಮನ್ ಸೈಟ್ ಫಾರ್ ಮೆಟಾಸ್ಟಾಸಿಸ್ ಇಸ್ ಲಿವರ್ ಆ್ಯಂಡ್ ಲಂಗ್. ಫಸ್ಟ್ ಲಿವರಿಗೆ ಹೋಗುತ್ತೆ, ಅದಾದಮೇಲೆ ಲಂಗ್ಸ್. ಓಕೆ, ಐಸೋಲೇಟೆಡ್ 3 ಮೆಟಾಸ್ಟಾಸಿಸ್ ಟು ಲಿವರ್, ಲಂಗ್ ಆ್ಯಂಡ್ ಬ್ರೈನ್ ಕ್ಯಾನ್ ಬಿ ರಿಸೆಕ್ಟಬಲ್. ಅದಕ್ಕೆ ಮೆಟಾಸ್ಟಾಸೆಕ್ಟಮಿ ಅಂದರೆ ಕ್ಯಾನ್ ಬಿ ಲೋಕಲೈಸ್ಡ್ ಆ್ಯಂಡ್ ದೇ ಕ್ಯಾನ್ ಬಿ ರಿಸೆಕ್ಟೆಡ್ ಅಟ್ ದ ಮೆಟಾಸ್ಟಾಸೈಸ್ಡ್ ಸೈಟ್ ಬಟ್ ನಾಟ್ ಅಟ್ GIT. ಓಕೆ, ಸೊ chemotherapeutic agents now we use only in metastasis are irinotecan, cetuximab and bevacizumab. ಇದು ಓನ್ಲಿ ಇನ್ ದಿಸ್ ಕೇಸ್ ಮೆಟಾಸ್ಟಾಸಿಸ್ ಆಗಿರೋ ಸ್ಟೇಜ್ 4 ಅಲ್ಲಿ. ಸ್ಟೇಜ್ 3 ಅಲ್ಲಿ ವಿಲ್ ಗೋ ಫಾರ್ ಫಾಲ್ಫಾಕ್ಸ್ ರೆಜಿಮನ್. ಸೊ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಪ್ರಾಗ್ನೋಸ್ಟಿಕ್ ಫ್ಯಾಕ್ಟರ್ ಫಾರ್ CA colon is staging, again TNM staging. Based on that it will depend ಎಷ್ಟು ಸಿವಿಯರ್ ಇದೆ ಡಿಸೀಸ್ ಅನ್ನೋದು. ಆ್ಯಂಡ್ ಸಿಂಗಲ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಅಂತ ಕೇಳಬೇಕು ಅಂತಿದ್ರೆ ಲಿಂಫ್ ನೋಟ್ಸ್ 1 to 2 ಅಥವಾ 2 to 3. More the number of lymph nodes involved, poorer will be the prognosis. So okay, this brings us to the end of large intestine. So large intestine we have mainly discussed 4 pathologies. One, megacolon or Hirschsprung's disease. Adadmele we started discussing about polyps. In that neoplastic polyps alli we have discussed 2, that is associated syndromes discuss ಮಾಡಿದ್ದೀವಿ, FAP and HNPCC. Non-neoplastic polyps we have discussed juvenile polyp, PJ syndrome and inflammatory polyp. Okay, after this we discussed about CA colon. Okay alva. So after this we need to know about 2 main procedures called as ileostoma or ileostomy and colostomy. So ivered procedure throughout the large intestine or throughout the intestine treatment we will be studying. So better to study it under a separate topic and finish it off.